I have a very ambitious title, as you can see, and this is something that a lot of people have been dedicating lately, trying to really to move forward in the field of major depressive disorder with prediction or precision medicine. I declare no relevant conflicts of interest, and I would like to show you here first a slide that summarizes the two most common. Perhaps the pointer is not really helping very much, but you have depression on the left side. I don't think against the screen it works. So on the left-hand side, you have recurrent depressants of episodes and an opposition to bipolar disorder, where also there is episodes of mania. And just to signalize that I'm going to be talking today about those on the left side. So we still know too little from bipolar depression, and in the case of what I'm going to talk today. MDD, the diagnosis is still done in an interview. Here is an example of a classificatory manual requirement for having a major depression, and you can see that basically it's all based on interviews and clinical scales that we apply in the clinic. I think the most striking part is that depression has only been one of the leading causes of disability. It's being spread all over the world, and the numbers are huge and are not decreasing. We have about 700,000 suicides each year associated to that, and I think probably the most striking number is that about a third of those patients do not respond to any conventional treatment, namely antidepressants, with the long list of antidepressants that we have in hand, as well as different types of psychotherapy. And a third, so about 33%, is really a very, very big number that tend to chronify and really bring a big burden for this person's life, society, and everybody. So RTMS has been an alternative more recently to this. It's an established procedure, so it's really recommended for those that are treatment resistant, namely 2 antidepressants in the correct time and correct doses from 2 different classes. So basically, if they do not respond to this, you can already establish most of the country's treatment with repetitive transcranial magnetic stimulation, which is very good to start with because it is bringing very little side effects. So it's generally a very, very good modality to be applied. It can be used as well in combination with antidepressants in case patients have partially improved with the antidepressants. There's basically no problem to combine that. It might be the interaction is even more effective in that sense. But so far, the issue is we still work on this model of one fits all. So basically, we really try a certain type of antidepressant, we really try a second type of antidepressant, and then we try RTMS. This works really well if we look at the proportion of the disorder response across the world, but it doesn't really help us much further in terms of precision medicine. Precision medicine will be, on the other hand, some way of identifying a particular subgroup of patients that could have higher chances of responding to medication A, B, or C, or a certain intervention such as RTMS. And I think that most of the efforts have been put today on really moving this and paving this path that has been established, for instance, way more in oncology, in the psychiatry field. And with that, we really aim that the response is boosted, and we have way less side effects and or no response at all from patients' side. So today I'm going to be talking about a couple of experiments that were ongoing and are still ongoing, and how we could actually establish this forward, in my view. So I think that research developments to achieve personalized treatment in depression would involve, for instance, an individual selection of where to stimulate with rTMS. So even though patients have been responding to this treatment, about 50% of those patients that are refractory to antidepressant therapy have been successfully profiting from this. So it is something that we could possibly still implement and improve quite a lot, because it's a very powerful tool we have. You can actually modulate a certain region of your brain non-invasively. We do that even in a potentially outpatient situation, so it's really fantastic to have that in hand. And what I'm going to guide you through today is the possibility of maybe using some brain information to increase this benefit of what we already seen, and in particular a new treatment protocol called ITBS, so intermittent theta burst stimulation. The second point I'll bring today is if we could perhaps use with brain information as well a way of clever AI, so machine learning or deep learning approaches to identify who is indeed suffering from MDD versus other potential disorders, and as well trying to see if alterations in the brain could inform us how severely depressed this person is, and as well if this person might respond to our rTMS, which is one of the nicest things one can actually achieve to move forward with precision medicine in this field. And the last point is about just a very quick overview of a grant we just received to move this last point forward. So just briefly summarizing here a very complicated and extensive part, which is the fact that our brain is organized in regions that preferentially work together, and we look at that generally with functional connectivity. We can either see it in a specific region, and with that region, such as, for instance, you see on the left the default mode, when one sees the posterior cingulate cortex, you can actually see which other regions in time have been activating and deactivating in a similar fashion, a similar pattern. And then cross-correlating with the whole brain, you get this image which represents the network itself. Another way of doing this is not seeding in a specific region, but is actually getting the entire data set and throwing through an algorithm that will separate that temporal-spatially and allow you to also identify the default mode, as you can see on the right side, on the third position, which are obviously the exact same regions. The difference between those two techniques is that in the first one, you would select a particular region, and in the other one, you will not. You would just basically let the data run by itself on the algorithm, and that will split on its way. The advantage of this is that you may take better coverage on the second approach of individual information. So perhaps on the first one, if you fixed a seed, you might be seeding the exact point where the node of that network is. But on a second subject, you might miss it, or you might actually be even in a neighboring seed or region, as I'll show later. So I'm very keen of the second approach that basically splits the data for the subject by itself. And by looking at that, there's also the seminal image showing what I was talking before, that some of those regions would be activated and deactivated a long time. And what you can see here in this plot below that shows the time courses is that these networks are orchestrated, so they seem to be really organized in ways that some networks take over the activity at a certain point, whereas it deactivates in time and another network takes over. So this kind of anti-correlation is also very common in our brain. It allows us using different cognitive possibilities and resources we have in the brain according to a certain situation. If you have to actually connect and use information from your introspection, so from yourself, your memory, reminiscent information, or if your stomach is actually signalizing to you that you are hungry. So this is one type of information will be captured by one type of these networks, and whereas you have to suppress this and then pay attention to what you have to present to the audience, it allows other parts of the brain, and then of course integrating this information and having this both sides and deciding which one I'm actually wanting to focus at the moment is something that we generally have and use every day, but is lost in depression. In depression, what we see is this scheme on the right side where the default mode network takes over, and this introspective resources, this negative rumination, and the inability to focus on the outside world and counterbalance this emotional negative side is something that we commonly see in patients. On the counterpart, many of them also have cognitive deficits, which is basically this inability to concentrate on stimuli from outside and perform well in that sense. So it really, the concept will be that basically there's an imbalance between those networks. And RTMS, as one of the hypotheses, would basically bring back those regions that have been out of play and allow an stabilization between the systems again. So this would be the theory behind the network mechanisms of RTMS. It's still very basic, and there's a lot of research to do. But if you look at this interesting figure here, you could see that clusters of depression are represented in there. It could be the psychomotor, cognitive, emotional, neurovegetative. And those circuits, they've been really well characterized as well by imaging studies. It could be that if you have a particular person with a certain combination of those clusters, which is generally what we see in the clinic, it might be that certain circuits are altered. And this person could be equally depressed as somebody who has a completely different pattern. So we see that in the clinic as well. And the idea here would be if RTMS could be as precise as a modulatory influx of energy to a certain position of the brain, perhaps we could actually target the optimal position where this influx of information should be, so that we can actually help people in a more individual and more particular way. So this is really the potential of using precision medicine with this type of treatment. It is a very interesting treatment in my view, because you just don't give a systemic medication or a systemic approach or a systemic influx of energy, but you really can target a specific position. And indeed, this has been out in the literature a lot, so a lot of studies been replicating this same idea. So what they do is they look at patients that have been under RTMS, and they look as well how their resting state networks have been. And they really evaluate that according to the position that would actually be traced to the rostral or the subgenal ACC, we could perhaps identify the dorsolateral prefrontal cortex, or generally where the stimulation takes place, in the exact point where this stimulation will be beneficial for the patient. So this is being frequently replicated, and you could see that it's called personalized functional connectivity guided target. If you are close to this optimal point, then you would expect the patients to respond more from this therapy and to have even a higher clinical improvement. So this is what the graph there on the right-hand side shows, is that the closer you are to the optimal point based on resting state information, the more you will have the clinical improvement. And this has been shown in their data set. The interesting part here is that frequently this has been done in this fashion, but never it was set in the randomized clinical trial, so which you would compare the individual position, optimal position for subjects, versus a general position, that is the one that we use in the clinic, and then compare the benefit between patients. And that's exactly what we wanted to do. So this is a nice paper as well that compared, for me as a first picture, how the group versus the individual description of networks can be. And you can see the fine-grained distinctions between the individual position versus the group. And if you indeed would see it, I don't have a pointer now, but if you would have the second panel here, right to the lower part in this red region, you can see there's some yellow points in there. And if you were basically seeding this region for every single subject, in some subjects you might fall in yellow, in some subjects you might fall in red. So you're actually taking different networks, and this isn't really the most precise way of informing this. Based on this, instead of doing this seed-based analysis, we focused our randomized clinical trial on the entire network, the default mode network. And the idea was basically that we map those networks, we select where the optimal point is, we stimulate, and then we see the response afterwards. So we actually see also what's going on with those networks. It's a complex pipeline, but it's generally the state of art. We basically developed this target selection pipeline in the lab, and it was basically based on the anti-correlations, flipping the default mode network and trying to see where exactly in the other, for instance, frontoparietal network, this overlap will be, and that will be there selected the strongest point for stimulation, and we move on to stimulation. So it works more or less like this. To give you a general picture, the subject comes to us. So this is a simulation from the former lab members. We have a lot of information, including the clinical scales we want to control for and measure, and they go into the scanner, and then we overlay the individual information from the scanner, the structural part, with these functional information we have in this flipping networks I just told you about, and seeing the optimal overlap between green and red, which is in this case yellow. I have a video here, and maybe we could run. If you click on this last picture, yes, I think it's running. If you go down and press play, no. So yeah, I hope it's running, yes. So this is just for you to understand how it happens. We have here in the bottom the stimulator and the coil, and there what we do with the information we receive from the scanner, we create online dummy of this person. So basically you see an avatar there with information of where the head of the subject is in space. Through specific cameras and these little balls that signalize this. And once this has been constructed, you can actually see live the brain and the information of the person, and you can really navigate to the optimal point of stimulation with precision of millimeters, and it's this really nice neural navigation setup that one can use. This has been also established for instance, a description of where operations in epilepsy can or cannot take place. You can also go to specific areas and use RTMS to inhibit certain areas and see, for instance, if those areas would potentially bring damage to patients. So this is a technology that we also used in here to have precision in the optimal position of stimulation. And patients then go back to the scanner and as well as the battery of scales. And sorry, I was going backwards. So we did 2 studies, basically on this part. We defined that as basic sphere. So one trial was running with a 10 hertz RTMS, and the other with ITBS, with 23 and 26 participants, healthy controls. We wanted to see if this protocol that we just created there really works, and it really decouples the DMN in the position that we were interested in really having. So for that, we ran an entire RTMS session, clinical session in healthy volunteers to see the effects in the brain. It's a bit of a complex design, as you can see here, but we wanted as well to control that for a sham stimulation. So what we do is we stimulate the exact same way, but there's no electromagnetic stimulation. We have instead electrodes that are always giving a skin sensation that you are having a stimulation, so you can indeed mask that for patients and mimic basically the effect of being stimulated. And most of those participants as well as patients, they have never had RTMS, so they don't know how it feels. So it worked really, really well in that sense. We wanted as well to see that participants would receive, the same participants in one hand, real versus that sham, but also that they all receive the real stimulation after all. And in the translational sphere, we used the best results we had from the basic sphere to 82 participants that went up to the end of the study in a similar way, following up with until week 6. You can also simulate this kind of information. It's really cool because you can put the brain information of the participant and you define which coil you're using. You can actually see how much of an effect that creates in the brain. So this is called field modeling. And what we wanted to be sure is that our protocol is very consistent. So we used for each participant 2 data sets, individual data sets, and we used this exact same method to see if we would be landing in the similar position as we expected. And this you can see in day 1 and day 2 for subject 1 and 2 here represented, but we actually did that for all subjects. And considering that the diameter of the stimulation, the strongest part, goes about 2 centimeters from the coil, which is the red line you can see in there, we consider that sufficiently good that biggest majority was inside of this exact same area. So going to the information of the disconnection of the DMN, on the top panel you see 10 hertz with the differences to baseline, as well as the first 10 to, yeah, I didn't say that, but here you have If you look at the chart on the top, you can see the time. So R0 is before stimulation. Then you have 10 to 15 minutes, a first block of resting state, then 27 to 31 minutes, then 45 to 50. And these are the blocks of resting state we're looking into. They are resting 1, 2, and 3. We have somebody in the scanner for as long as an hour after the stimulation, and we wanted to see how the networks are changing in time. And the strongest difference we saw was after 30 minutes, where you have indeed this perigenual to subgenual disconnectivity of the DMN that extended up until the nucleus accumbens on strongly on the right side. And ITBS in the counterpart was a bit more dorsal in the anterior part, but also a pregenual disconnection. And interestingly, after 30 minutes, it expanded to even a stronger and larger area in 45 minutes. And that extended up until the insula on the right side as well. So this is an effect that we could see. For 10 hertz, it was less than an hour. For ITBS, it maintained itself for longer than an hour of evaluation in the resting state. So we selected this one for being the more robust for the clinical part. And in the clinical part, unfortunately, I don't have the final results right now to tell you if the individual versus the general stimulation shows indeed a very consistent difference. But you can see here in this first graph that in between V1 and V2 is a week of stimulation, and between V3 and V4 is a second week of stimulation. And the participants that have received sham, they do respond quite a lot from the placebo effects, but it doesn't look like they are maintained. So they tend actually to go higher back to the stronger scores in MADRS, whereas those that receive the real stimulation, they have even a lower manifestation of the scores. So we could see that basically the second, so this sham active group, the light blue, the moment that they receive the real activation, we indeed do not see differences anymore in between the groups. So this gives us a clear hint that it works. It indeed works to stimulate with the real ITBS protocol and not using sham. It's not only placebo what we are seeing. And interestingly, it's an accelerated protocol, so I didn't say that before, but I think this is gonna come very frequently for us in the future. Instead of using one session of stimulation a day, we packed together 4 sessions a day. With respective pauses between the sessions. And that accelerated the entire treatment. So what we are seeing here are patients that are responding within a week only, instead of a month. And that is the exact same doses. So we packed more sessions in one day, and we delivered the amount of pulses faster to them. And frequently I'm seeing this in the clinic, the patients actually tend to respond already on the 3rd day, which is amazing. The other thing we wanted to look into is how suicidality would be in this. And we didn't really have perhaps the optimal way of measuring this because it was all on the individual items as people have been doing in the literature of the scales we traditionally run. But we can see that there was a decrease, but not a difference between sham and real, as it shows here on the plot. However, important aspects such as anxiety and impulsivity, which are really important aspects, part of suicidality and suicidal behavior, they did reduce a lot. So this is really very promising in my opinion. As an extension of this work with the accelerated protocol, we had a couple of collaborations recently. This is with colleagues from China, and they put together our study in the bottom with Belgium, USA, France, and Sweden. those that have been using this accelerated protocol. And we have differences in those protocols, but what binds us together is that we use that in an accelerated form. And you can see that there's also a very promising direction favoring the use of the accelerated ITBS for treating these symptoms. We need more studies on this direction, but I really believe this is something that's going to come very frequently. With another follow-up collaboration with colleagues from the Netherlands, this has been taken to more details. And what you see on the top is the S&T, so the Stanford protocol is being very frequently called out everywhere for being a wonderful protocol for treating depression. And you can see that basically by doing not 4, but doing 10 sessions of stimulation a day, this might be actually even a better protocol. The only challenge is, of course, to have patients for 10 sessions, because believe me, in 4 sessions, they already want to go. They are tired of the whole experience, even though it's not painful, it's just very demanding for the whole day. And then having them participating in 10 sessions is actually very challenging. I even asked myself if this could also bring some selection bias, because those that stay up until the end of the study for these 10 sessions maybe are a cluster, a type of group of patients. It's a possibility. But anyhow, it looks very promising, but as I said, the information of resting state improving the clinical benefit is still work in progress. I don't have an answer today. I want to quickly jump into the second point I find very important, which is the classification of patients versus controls, and possibly subgroups of patients by using brain information. And this isn't a new point, so people have been doing this for a while, and you can see here in the charts the number of studies from publication from 2018. There are more studies today. What it calls our attention, though, is here the total sample size. So in the bottom graph, you can see that generally you have a total sample size that frequently do not cross 200 participants, which is way too little for a machine learning approach. And with such small numbers and samples, you can actually get an accuracy of this task that varies from 100 to 50%, and 50% would actually be nothing. It would be no ability to differentiate the groups. Another paper that calls attention to the effect of the sample size versus the performance, the accuracy, is this one. It's a more recent paper, and there you can see also that above 300 participants, generally the accuracy in detecting participants with the diagnosis versus healthy controls is very, very low. It's basically nothing. So we wanted to proceed with a proper sample size, and with that we used the data from the Enigma MDD working group, which is a very great approach because it has so many data sites from all over the world, which is important from machine learning for reproducibility as well of your results. And they are pipelines that have been tried out many times and validated, and there's a lot of quality control in this data set. So this is really a wonderful opportunity to investigate this differentiation. And we have from the output of FreeSurfer, which is this platform we use for the analysis, over 68 parcels of the brain in each hemisphere, as you can see here in different colors, as well as over 37,000 points, which is called here vertex. These are the intersection between those triangles that you can see in there. And you can get cortical area and cortical thickness information, as previously discussed and presented also by Andre. We used two classifiers for this project. In study one, we used a support vector machine, which is really trying to find the optimal plane that separates the two groups. In the second classifier, it's a bit more complex. So it's a convolutional neural networks, which is really a way of trying to simplify the images with the features that are most informative for this classification. So it really goes into simplifying this picture as much as possible and maintaining the features that would really aid the classification. So this is a bit of our pipeline. It's a bit complicated. I'm not going to go into the details here, but I just wanted to tell you that we use support vector machine, logistic regression, lasso, ridge, elastic net, and random forests for this classification. So we really tried many classifiers from the side of machine learning. And there were two ways of organizing the data. So we tried to split the data by age and sex to have that balanced in the 10-fold cross-validation, as well as splitting by site, by having a site that has not been identified at all, set to classification and see how good this can be done. And the second study is perhaps even more interesting because we used thickness as an information that is seen to be very important, together with curvature and so-called depth. And these three informations for each participant, we combined in a projection that reduces distortion as much as possible, is the OAMT projection in there. And by each person providing such information, we wanted to see if DenseNet, as our representative of the convolutional neural network, or support vector machine will be doing a good job in this classification. And so this you see organized in a different way. So the ROIs are there in the right side and the subject-specific features in the middle. We have the extracted features that we use for the classification, and these are the results that we got. So basically, it really attests that it cannot do a good job with the structural information so far. So we have really large samples in here, and it really doesn't move much better than this. So the question is, what do we do? Should we just give up? And that brings me to the last part of this talk. It's actually a pleasure that my student who co-authors this study is also known for some of you. What we did is we summed up thousands of publications, and with this you see about 60 describing different interventions in depression and which areas they have published. All these individual studies, they identify that a region is either a predictor or this region changed with this intervention, or both. And on this side here, you can see pharmacotherapy, psychotherapy, ECT, and RTMS. And if you look for a couple of minutes to these pictures, it's actually very striking that the regions seem to be the same. Commonly, we have an overlap of those regions, and it seems basically the resting state functional connectivity could have the possibility or maintain the ability to perhaps inform us who will and who will not be responding to a certain treatment. So with that, we just received a grant from the NIH to move forward. and this goes into the global deep learning initiative to understand outcomes in depression. It's a pleasure to have this board of very great, important researchers with me in there, and obviously all under the umbrella of Enigma, Central, and Paul Thompson. We are going to collaborate with that internationally, and the plan is basically to dig into the functional MRI in a different way, in a way that has not been tried out before. And this way is basically by putting an image for every person's brain and subject-specific features, and then combining the structural information and the functional information in one or a simple picture, and really seeing if the classifier can do a job of really defining who is depressed, but also what is the severity of this depression, and really looking at the potential features that inform this definition. So this is just an example and as a diagram of how we will proceed further. And the interesting highlight here is that we're going to have about 60,000 participants taking place in this by merging Enigma MDD, the rest Meta MDD cohort from China, and UK Biobank from UK. And we really would like to see if then our classifier does a better job on this classification regarding the symptoms, obviously. Then we will afterwards test that in an independent data set from Göttingen from my side, and Cornell from the US, the leading part of Adolescent, and we want to see with about 400 participants that underwent RTMS if the classifier can do a good job also in identifying who will be responsive to the intervention. So this is a bit of a more detailed slides on this resting state schemes of defining the strongest nodes and the boundaries of regions. We did not develop this. It's been out there and developed by Cohen and Weig for quite a while. And we find it very fascinating as a fingerprint for every brain organization of the subject. And what we did is we extended this pipeline to the three-dimensional brain, because we know that other areas, not just the surface, but also basal ganglia could play a very important role in depression. So we extended that to the entire brain. And what we did here is the first step is we used support vector machine to see if the support vector could actually detect the periods and the regions where after stimulation of 10 hertz with RTMS, we can see those changes, and it could. So it did a good job of finding up to 75% of the time and the regions, and both in the nodes as well as in the boundaries. And these regions, as you can see here, is highlighted in orange. And then if we get to nodes and the regions that belong to boundaries, and the time that they've been the strongest in this, actually from this intervention of 10 hertz RTMS. So it's very promising, and I'm very excited with the new perspectives, and I'm also extremely grateful to all collaborators from Enigma, to which also Professor Ganu is also part of, and Paul and Sophia, who did an amazing job of really keeping this consortium together. It's a really big pleasure to be part of it. And I thank, obviously, my lab members. Without them, I would never be able to do all this amazing work. They've been fundamental for this. I thank also the institutions that funded the work, and I thank you all for your attention.